Let's start with the second. So it's all about how the patients are feeling. We come from a history where it's more important to say what doctors say than the patients. Now we are in an interesting age where this the opinions of patients are becoming more and more important. So you probably know this. Got it from the internet. This is these are the SDGs, Sustainable Development Goals, 17 by the WHO. Yeah. And one of these sustainable development goals is good health and well-being. If we remember the Ottawa Charter in 1986, there was this health promotion postulated. And this is important because health promotion is the process of enabling people to increase control over and to improve their health. So it's important for the people to have something in their hands to get more and more healthy and to increase their well-being. So it's important to think about what our patients think about what we are doing with them, so they can decide. And this is mainly summarized as health-related quality of life. So we think about the objective data, imaging, lab. This is something that we are very, we think it's very important. And this health-related quality of life augments these clinician perception with the sensations, opinions, and functions and quality of life of the patients. And nowadays, so this is a very, I recommend to read that, operationalizing PROMS at the musculoskeletal practice and policy levels. So PROMS is patient-related outcome measurement. So this is something, a questionnaire that you put a patient in front of him, and he can, by himself, go through and say, this is something I can decide, and this PROMS, and I've structured this lecture about in these 3 sentences. So this is derived from this literature piece of Bernstein, which is very actual. Using patient-reported outcome measures clinically from the individual patient to population health. So this is, you will see, not only important for the patient, but also important for us as doctors, and also for development of societies and healthcare in general. So, and how can we optimize the routine administration and collection of these patient-reported outcome measures? This is something I will especially deal with. And then patient-reported outcome measures from the point of policy. So these 3 things, you will hopefully get answers in this lecture. Over 80 billion of patients on Earth. So very many diseases, different diseases, and for every disease a specific PROM. So there's a lot of that. So I've decided to bring you just some PROMs, just to be sure that we can maybe understand how PROMs work. So as a tumor surgeon, I'm very keen on bringing PROMs, of course, from the tumor sector, from the orthopedic tumors. And what does PROMs in the tumor setting what is important about that? Is it wish or reality, this child? This is from Anderson Cancer Center. The running child with the history of a distal femur osteosarcoma. It's important to have this functionality. This was what was most important over the decades. We wanted to keep alive the patients with osteosarcomas and Ewing sarcomas and sarcomas in general. And you see these survival rates of bone sarcomas, soft tissue sarcomas, and gastrointestinal stromal sarcomas in different parts of Europe. But you also see that survivors of sarcoma do fail activity guidelines when compared to their siblings or compared to normal population. And this is some objective data where you can see that patients after tumor prosthesis of the proximal femur, distal femur, proximal tibia, and the knee extension strength, they do not really good. And here also the hip adduction. Yeah? So there is room for improvement. And the history showed us that the system for a functional evaluation of reconstructive procedures was founded from the MSTS. This was quite simple, pain, function, emotional acceptance, supports, do they use supports, and very easy to understand. And then this was in the 80s, and in the 90s, the Ottawa Charter that we saw made us more think about what do the patients want to improve. And we have this new measurement by Davis. It's called the TESS. And you see that these factors are very important for the patient and not really objective. But how do we use these instruments? They, of course, give a kind of measurement. And when we compare the different studies about, in this case, distal femur reconstruction, we see all these patients are nearly the same. So we think about a ceiling effect of these scores. But what is important is that we should use these instruments as a follow-up. We have to use them before surgery and to different time points after surgery to really see what these new measurements bring. And you cannot see, in this case, that there are subpopulations who want to do more. They want to be very active. So we made a study with functional outcome with the UCLA activity score, which is a sports score. And you see that patients who are very active before are very active afterwards. So no matter what kind of reconstruction they get, they take something of their activity from before surgery with them in the period after surgery. And this is a kind of quality study to show that it's very, very important to also tumor patients to be active more. And it's very hard for them only to sit around and nobody cares about their activity. So this is the UCLA activity scale. From 1, wholly inactive, depending on others, cannot leave residence, to 10, which is regularly participating in impact sports. And what we know about our patients with this kind of proximal femur endoprosthetic reconstruction, preoperatively they were quite high, and in the first year they were very low, and they somehow recovered to a kind of 6, which means regularly participating in moderate activities. And these are guidelines for these patients with sarcomas. You see, this is a vicious circle: hospitalization, functional abnormalities, long-term inactivity, and chronic disease. This is going like that. And if we do not give the impact to these patients, they wouldn't find their way out. And what is important? 150 minutes of sports per week. This should be done by you all. Okay, and we see that these patients with different reconstructions after tumor, they do not really reach that. And we also have to think about if certain reconstructions do not achieve or make it achievable to get these sports, there are different cohorts with amputation and rotationplasty who do. So when the patient starts to talk with us what he wants, we are in a kind of problem. Shall we give him the prosthesis, or does he want the rotationplasty? So we have to think about what is important to the patient, what is manageable, what can we do. But it's important to see what patients otherwise are able to do. What we saw when we were so we started to make an opinion survey among tumor surgeons. What do they think about this activity? Because they somehow, in some countries, felt offended by patients with tumor prosthesis not only walking but also running and doing sportive things. So we wanted to ask, how do tumor surgeons see this? How would they recommend these tumor patients doing sports? And we saw that in this More Sports survey in 2016, this was the recommendation: regular participating in active events like bicycling. And we asked them about the different kind of sports. So proximal femur hemiprosthesis, walking, swimming, stationary bike, even golf. Yeah? Proximal femur with total hip replacement, like that. Distal femur, low impact aerobic, proximal tibia. So not much, but we have had a kind of recommendations then. Yeah? Then we asked for sports that would be recommended if they were doing these couple of sports before the surgery. And this was okay for many of the colleagues in the opinion to do these sports. And there were only some sports beyond the limits of recommendation, which were mainly very high active sports. So this is the thing that joins all these efforts together. And the colleagues, they were from the different tumor societies asked. And what do you think was the problem for many surgeons to recommend very active lifestyles?
They were afraid of complications.
Of course, of course. And these were the most they were most afraid of complications. The periprosthetic fracture, yeah, the allograft fracture, the early polyethylene wear, and dislocation of the hip. Of course, in different reconstruction methods. This is just summarizing the whole data. Yeah, and how can we manage that patients are more active? Yeah? And how can we avoid complications? Yeah? This flowchart is developed in a work by Kesting from Germany, suggesting technical supports in skiing, for example, skiing after tumor prosthesis. So you have this round table with adaptive ski instructors before and after surgery, yeah, talking with all the different disciplines, yeah, and discuss the mechanical obstacles, psychological obstacles, the individual goals. You see there's a lot of work to be done when talking about and trying to make things achievable for the patients. So when you remember the first slide, I showed you how to optimize these goals. Yeah? So the test score, which was the second score I showed you, yeah, with all the different questions, we started to routinely assess our patients. Then we started routinely with electronic questionnaire. And then we saw that these patients do not really, their response rate is low. What do you think? How many patients would answer an electronic scoring? So they were admitted to hospital for the surgery, yeah, and we started to tell them, so now you will have this tumor surgery, and we will start to assess your functional and quality of life outcome over the next years. What would you think? How many patients would? 50%, less. Great guess. Great guess. So yeah, we have this just showing the importance of so nobody can see the data. This is just a safety thing in our institution, yeah, where the link that was sent by email or by mobile is going through the firewall and back again. And we had these 230 patients with bone and soft tissue sarcoma, and we wanted to know how many of those would answer. And then we realized there were not much. And then we wanted to improve this by explaining the needs. And what do you think? Would just explaining the needs for this assessment give you a higher response rate? Let's see. So, yeah, this was the total response rate. So you were not bad. Your guess was not bad, 43. The response rate for patients with not explaining them was even lower, 35%. And with this, we had a lot of more patients, about 60% of patients who were accepting this and finding this is a good tool. Interesting, but not really unexpected, that the age was an important thing. Yeah? So below the age of 65, you had a lot of more response after this education, yeah? Not above. And what would you suggest, female and male, would be the difference? What do you think? It's hard to tell. But females were responding before in a higher rate than men. But females did not really improve after this, but male did. What do you think? Interesting finding, we didn't have an answer for that. So when you think about installing a kind of measurements in your institution, you think about this is really extensive work to do. You have to talk with your patients, you have to collect the data, you have to make them accessible, so that you can use them. But when you got this, it's an easy automatical way to get this information. And this educational information brochure is fine just to positively stimulate the behavior of these patients. Of course, we are not, we still have many questions to answer, how we can improve the measurement. I think I owe you some general considerations above these tests and tumor surgery. I think some important things about PROMs must be told here. So there are generic reported outcome measurements. You probably know that. It's the SF36 maybe, or this EQ5D5-IL. So in generic reported outcome measurements, you want to assess general well-being in a patient over all different of reconstructions, every different surgical approaches. This is a general assessment, which mainly deals with mobility, self-care, usual activities, pain, and anxiety. And there are specific PROMs, specific patient-reported outcomes. So these questionnaires you use when you have a very specific question for a follow-up of arthritis, knee arthritis. In this case, it's all about knee. And you can imagine very, very different questionnaires for any disease, every approach. The more specific you need answers, the more specific you have to elect or collect your data. And it's also important, this course, knee rehabilitation outcome score, consists of many, many questions. And it's important to collect very short, because you want to put your patients not into a long period of an exam. You just want a rough idea what the patient is thinking about. And this course 12 is consisting of 12 questions, and it's very easily to be assessed. And this is just to see how specific it is, because you have very specific questions here. Walking on flat surface. If I go back, you see that these were the most important single issues that differentiated patients with knee osteoarthritis. All of these PROMs have to follow quality criteria, of course. You need the validity, the reliability, and the objectivity. And what is very important as a measurement is the minimal clinically important difference. So, and the substantial clinical benefit. So, what is this? These are mainly the points in a score that a patient would see as a difference in his well-being. So this is something that is very important for every score, and this is also for this course. So you need to have a difference of 6 to 14 points that the patient would feel a difference when he was describing his score. Another thing that is important for these prompts is the readability. Readability consists of two main factors. The average word count per sentence that you are using. The more words in a sentence, the more complicated to follow what you are talking about. And the average of syllables per word. The more syllables, the more complicated. So, and there's this Flash-Kincaid reading grade level. This is from 1975, but still important. And when you see the 7th grade would be fairly easy to read. And if you take a look at all the prompts that are used in orthopedic surgery, you see that most of them have a grade level of 4 to 5, so they are good to understand. And only some are above 8. Interestingly, very hard to understand this UCLA activity score that we saw before. Easy to understand the knee outcomes score that we saw. How do we use these prompts? We use them to predict. So in this case, this is coming from data from the Osteoarthritis Initiative, which is about 5,000 people who were follow-up in America for over now about 14 years, collecting all laboratory data, all different measurements. And from out of this data, it was possible to calculate when a patient needs knee prosthesis. So this is also work done by our institution. So you can take this data, ask for if you can use it, and then calculate with it. And you see that when the pain is getting very rapidly very higher, and the quality of life is suddenly going down, then the patient, of course, gets this prosthesis. So if you collect your data very often, you can somehow predict when your patient is needs surgical approaches. You can also use the prompts for a follow-up, which is what I meant. So this is interesting data collected from 2 different randomized control trials. Just a short explanation. Patients who had total knee arthroplasty with a COAS score of about 45, 46, 47, improved a lot until 2 years of a COAS of 80. Without DKA, but with therapy, they also improved, but not at a high level like the DKA. And without even any surgical, non-surgical. But written advice, they also improved, but at a very low level. Yeah? So this is important information when you follow up your patients. Yeah? And if you imagine having electronic support, yeah, you can easily see if patients do not go well, and maybe you can ask them to come. Yeah? Maybe something is wrong. Yeah? PROMS follow-up is also different in different countries. We can measure that. And here also think back about the tumor questionnaires. Yeah? I showed you the mean of 7, which was recommended worldwide by tumor surgeons. But if you take into account Europe, Americas, and Asia, their recommendations were very different. So what was recommended in the Americas and Europe with kind of 7 was not recommended in Asian countries. We have to think about this, yeah, and come into discussions with colleagues from different countries why they would recommend differently. Yeah, we already saw this. So we come to the public health aspects. Yeah? So the improvement in % of a generic outcome like the EQ-5D, or the specific improvement of the COS of 22%, yeah, leads to quality adjusted life years. These are data from OECD. What does this mean? We can improve the quality of life, and also the policy, and maybe adjust our policies according to these new aims. There is also a questionnaire, like we saw before, for transfemoral amputees. You already saw that, yeah? And they are very specific. Yeah? So this is more and more, you see that, more and more becoming specific for even musicians. Yeah? There is this development and psychometric evaluation of musculoskeletal pain intensity and interference questionnaire for professional orchestra musicians. Yeah? Like in a very short form. Yeah? To assess specifically, yeah, the problems of orchestra music. You can imagine that patients that are musicians do really have very different importances than someone who doesn't play an instrument. So I slowly come to an end now by showing you or trying to summarize the different meanings of PROMS for all the different groups. We're showing these different perspectives. So the meaning for PROMS for patients should be the personal and independent input to healthcare system, because this is not usual. Yeah? If you go to a doctor and tell him this and that is something I want to do, you will never have the objective to see this in a high number. Yeah? Understanding for expectable outcomes. So if you tell a patient he can improve by this certain kind of points, he will get an understanding for what is possible to improve after his certain surgery. Of course, maybe the patient gets some ideas by using the questionnaire of what he could even think about and he hasn't thought before would be possible. So meaning of prompts for doctors. Improving and maintaining high levels of care through direct feedback. You seldomly get this kind of organized feedback without a questionnaire. Improving communication with patients, increasing awareness of problems. So if you have the same questions asked to different patients, you get different answers and you get a kind of feeling what the patients can do or cannot do. And this raises the awareness of different issues, and maybe you can change your therapy plan. And think about if you get this information electronically. This is fantastic. Finally, the meaning of prompts for the stakeholders. It makes, as you saw, comparability of outcomes at local, national, and international levels. You've seen this data. Yeah? There is identification of differences. We also saw some data about differences in the recommendations. You can start quality improvement initiatives based on very low scores maybe you're confronted with. Yeah? And maybe prompts could be the basis of this so-called value-based healthcare, where the distribution of funds is according to outcomes and not to the costs that a system needs. In the end, you can use prompts as a general tool for health information, the planning, program, and making policy. So that was this educative tool that we served our patients with that improved their collaboration with us by about 50%. And I'm at the end. So I thank you for your listening.